Excellencies, colleagues, good morning, good afternoon, and welcome to our event today, Gender and Immunization, hosted by the United Arab Emirates and United Kingdom Mission in New York, UN Foundation, and the Global Polio Eradication Initiative. My name is Rustam Hayat, Senior Communications Manager, and I'm honored, and it's a big privilege to moderate this session. We have a rich and fast-paced agenda, outstanding speakers from leading organizations in the vaccination and public health. Now, our co-host tasked me with two outcomes: help to highlight best practices in gender sensitization, immunization, but also ask the member states, implementing agencies, other stakeholders, to ensure that we are reaching every mother, every woman, and also provide protection for this number of female healthcare workers to make immunization work possible. I will accordingly do my best to firmly but quietly move us through the agenda and close at about 11:15 New York time. We will start from our guiding remarks from our co-host before moving to a panel discussion. I will then open up the floor for comments and inquiries from the participants. And Minister Wendy Morton from the UK will provide the closing remarks. So let's just jump back in. I would like to give the floor to Ambassador Lanham Nusaber, Permanent Representative of the UAE and Assistant Minister for Political Affairs at the Ministry of Foreign Affairs and International Cooperation. Ambassador, please, the floor is yours.
Thank you, Rustam. There was a little bit of a problem with the sound when you were speaking, and I just want to verify that it's now okay with the tech team before we continue. Can everyone hear me clearly? Because you were cutting out quite a bit when you were introducing. Are we good? Yeah. Thank you, Rustam, Excellencies, colleagues. Thank you for joining us today, and I'm honored to be speaking alongside our co-hosts and, of course, this incredible lineup of panelists. And I'm also pleased that we're able to bring so much expertise together, especially at this juncture. And while it is uneven, COVID-19 immunization is underway, and the international community is simultaneously continuing or resuming other vaccination work that was curtailed by the pandemic. So I think that we're seeing the light at the end of the tunnel, but this is the window to get gender sensitization right. The UAE has been very proud to support a number of global health initiatives, from the RBM partnership to end malaria and the COVAX facility, to spearheading efforts to end neglected tropical diseases through the Reaching the Last Mile Fund. And we've been especially committed to the Global Polio Eradication Initiative through the Emirates Polio campaign in Pakistan, the first polio vaccination campaign to resume during the COVID-19 pandemic. What we have seen is that all these efforts share a common success and failure factor: the role of women. Polio is one of the strongest examples. The initiative's success would not be possible if the health caregivers were not female and could not enter private spaces, and if the programs were not designed based on the specific needs of women as patients. Furthermore, we note too, especially after the last pledging conference on polio in Abu Dhabi, which raised $2.6 billion and expectations as well on eradication, that our gains will be reversed if we don't keep this focus on gender. I think at the New York level, we've come a long way on the normative side. There is consensus that women and girls matter, and that all UN programming, including immunization, must account for gender. But when we get into the details and mechanisms of implementation, there is definitely room for improvement, including from donors like the UAE. So I'm hopeful today that we can identify actions at both the institutional and field level that best serve female workers and female vaccine recipients, and how we turn those actions into standard operating procedures. I'd like to share 3 thoughts today on such levers from the UAE side, especially based on our work with the Global Polio Eradication Initiative. First, that good intentions on gender need to be matched by good incentives for implementation. When managers know that they're going to be evaluated on how much they consulted with women, including women in senior positions, or including appointing women to senior positions, how much they address gender barriers like phone or transportation access, then their work tends to be more gender sensitive from the outset. So our ask here is to implementing partners make gender equality part of the KPIs for personal performance evaluations. Secondly, we need to keep pushing for equal representation where decisions are made. Women are 70% of healthcare workers. I've not seen comprehensive statistics, but I would suspect they're less than 10% of decision makers in many communities where immunization needs to take place, or even some immunization implementing agencies. And there's not going to be one viable cookie cutter approach, but quotas, advisory councils, and gender advisors are some of the tools that we have all seen yield good results. And we need to be vocal as member states about the importance of trying to find those tailored solutions. Third, gender immunization is never about immunization alone. It is part of a broader reflection of gender equality. The UAE is a major contributor to UN Women precisely because we see the value in trying to be holistic and long-term. One comment that really struck me in a previous event on immunization workers was by a speaker who observed that there's a latent outlook passed down over the decades that women have an instinct to be volunteers. The speaker said, "We are extremely grateful for these volunteers and couldn't vaccinate without them," but that she would suggest women also have an instinct to be paid for their work, a latent instinct, shall we call it. So in the same way that successful immunization work considers water and sanitation, education, roads and clinic access, among other variables, gender in immunization needs to be connected to an overall policy commitment to gender equality. I think we in New York are well placed to advocate for that integrated approach through the UN system, and it will remain one of the UAE's top priorities during our seat on the Security Council in 2022-2023. So I look forward to hearing from our speakers and guests about their recommendations on gender sensitization, and then making sure that we seize this opportunity of unprecedented scale to put gender at the heart of immunization. And thank you again for convening.
Thank you, Ambassador. These are very great and very concrete recommendations to kick us off. And I would like now to turn to Ambassador Jonathan Allen, Deputy Permanent Representative of the United Kingdom. Ambassador.
Rustam, hi, it's Sophia. I think I may be going next. Ambassador, I was told that Ambassador Allen is running a little late. Is that correct?
Then allow me then to introduce.
Hi, I'm here.
To
Great.
introduce Ambassador Sophia Borges, Senior Vice President and the head of the New York office of the UN Foundation. And apologize for this and for this change. You, Ambassador.
I'm so sorry, Rustam. I've just heard Ambassador Allen come through on my headphones, so I'm going to cede the floor to him because he was next on the speaker. Sorry for the confusion. Ambassador Allen, over to you.
Thank you. Sorry about that. Yes, the link I was given brought me in as a member of someone watching the panel rather than being on the panel. So sorry about that, but we've managed to sort that out. So that's great. And a big thank you for inviting us today. And I, as always, listen with great attention to what Ambassador Naseba, to what Lana had to say. And I really liked the point you made, Lana, about, what was it, latent instincts or something? Yeah, I couldn't agree with you more on that. So look, it's a great pleasure to be invited today. It's a great, I'm going to sort of congratulate you on bringing this topic of gender to this discussion, which not only is now, but is a sort of live discussion out in the world about how we deliver sustainable immunization services. We are committed as the UK towards improving health and gender equity and defeating disease. And equitable access to vaccinations is going to be key in ending this pandemic. It's why we're such strong supporters of COVAX, having managed to secure G7 members pledging up to $7.5 billion in support of COVAX. But there are still big hurdles. And I'm hoping that today's panel will help us to reflect and learn the lessons from polio as we continue to fight COVID-19. Polio has taught us that making a real change does not happen easily or quickly. We must challenge ourselves to make far-reaching and structural shifts that will benefit the whole global community. And women must be at the heart of this effort. So look, I'm looking forward to hearing from the panelists and of course from the UK's own polio gender champion, our Minister, Wendy Morton. Thank you very much.
Thank you, Ambassador Jonathan Allen. So this was Ambassador Jonathan Allen. Thank you, Ambassador, and apologies for the mix-up. I think we are backtrack on the agenda. Thank you for your remark. And from here, would like to move to Ambassador Sophia Borges, Senior Vice President and the head of New York Foundation. Ambassador, over to you now.
Thank you so much, Rustam, and sorry for having contributed to the confusion. But good morning, good afternoon, everybody, and delighted to be co-hosting this event. And thank you for joining us today. Let me start by thanking Ambassador Nusabeh and the Permanent Mission of the United Arab Emirates for hosting this session and for leading the world's response to the imperative for gender-sensitive approaches to immunization. Let me also thank Ambassador Allen and the Permanent Mission of the United Kingdom for their partnership and unwavering commitment to gender and immunization, two interlinked issues important in the battle against COVID. As the international community comes together to build back better from COVID-19 and prepares for the upcoming deliberations at the World Health Assembly, the interlinkages between gender equality and health outcomes are paramount. The disruptions caused by COVID-19 continue to have a devastating impact on all essential health services, including the polio program, threatening to reverse hard-won progress. To achieve the immunization outcomes we so desperately need, we must redouble efforts to mitigate risks that women face daily. We must work together to ensure equitable vaccine coverage, regardless of gender, encourage programs to utilize sex-desegregated data to ensure that no one is left behind, and above all, support the gender-responsive approaches that are proving so crucial for the success of immunization programs, including the rollout of COVID-19 vaccines. I would like to thank our partners, the Global Polio Eradication Initiative, for sharing timely examples of how innovation, equality, and the empowerment of all women at all levels are central to progress. While COVID-19 challenges health programs around the world, there is an opportunity to create a healthier and more equitable world. But we won't get there without a concerted focus and applying a gender lens to all aspects of our programs. Polio infrastructure, including the millions of women on the front lines, must remain central to the COVID-19 response. The UN Foundation remains a staunch supporter of the UN's important role in reaching women in the hardest to reach communities. To that end, we work very closely with the UN Women to support the Generation Equality Forum as a mechanism to respond to the disproportionate impact of COVID-19 on women and girls. I'm also proud to note that our very own Geeta Rao Gupta is a committed polio gender champion. The United Nations Foundation is proud to stand with the international community to ensure that innovations in health and gender equality support women on the front lines, a first but essential step towards finishing the job on polio, ending preventable deaths, and rebuilding strong and resilient health infrastructure. So thank you all, and I look forward to hearing from our expert panelists and to a rich discussion. Over to you, Rustam. Thank you so much.
Thank you, Ambassador. Building on your points, we will make a quick trip to the field for an impression of context for female immunization work is to give us a little bit more of understanding what they're really facing in the field. So we're going to have a short clip. So if I may ask IT colleagues to show us the video.
کې مثلا چې زه کله دې کار ته راغلم د ډېرو مشکلات سره اخته وم په دې خاطر چې په فیلډ کې د نارینه‌و سره مخ کېدل وه هغوی رنګارنګ خبرې کول وم په دې خاطر چې د ښځو ونډه په دې ټولنه کې بیخي ډېره کمه ده کوشش کوو چې یو داسې کاري زمینه ورته برابر کړو چې هغوی وکولی شي چې د کوره راووځي او خپل استعدادونه خلکو ته وښيي موږ چې کله سهار 8 بجې رسمیات تر 4 بجو پورې 8 بجې چې کله د کور څخه راووځو لومړی خو ځو هغه کوم روغتونونه چې وي د هغوی څخه لیدنه کوو د هغه هیلث سټاف ته اورینټیشن ورکوو لکه څنګه چې مخکې درته ویل د اف پی په اړه باندې یعنې کوم کیسونه چې وي هغه کیسو په اړه باندې وروسته له هغه څخه کوویډ 19 په اړه نو کله چې کوویډ 19 راغلی نو د هغه تر څنګ چې موږ کوم کیسونه چې راپوروو تر څنګ مو کوویډ 19 کیسونه هم راپورول
You're muted.
Rustam,
You're muted.
Not hear you.
You're muted. You're muted.
I'm sorry. I think looks like I was on mute, and sorry, we are grappling with technology. So, Excellencies and colleagues, I'd now like to move us to our second agenda item and introduce our esteemed panelists who collectively represent decades of first-hand experience with many types of immunization work in some of the most challenging environments on the planet. Our panelists today are Dr. Ahmed Al-Mandari, World Health Organization Regional Director for the Eastern Mediterranean, who is also one of the passionate advocates of global polio eradication and gender champions. Then we'll have Dr. Sagri Singh, Senior Advisor on Gender and Equality at UNICEF, which has helped to reach nearly 800 million children with life-saving vaccines in the last 20 years. Then I'd like to introduce Jean Munro, Senior Manager for Gender Equality at Gavi, which helped us to vaccinate almost 50% of children of the world. And lastly, the remarks will be closed by Dr. Sebastian Taylor, Head of Global Operations at the Royal College of Pediatrics and Child Health in the UK, and he's also part of the Polio Technical Advisory Group for Afghanistan and Pakistan. Dear panelists, in the interest of time, I would be grateful for your briefing and also like to welcome your personal recommendations on the top of the asks member states and implementing agencies on gender sensitization, own experiences, and observation. If I can turn to Dr. Ahmed, if I can turn to you, I would be, in your office, some of the most challenging environments for immunization, often involving remote communities and diverse traditions and gender roles. You also have personally been a key voice for female healthcare workers in these environments. And this will be also discussed in the World Health Assembly. Could you tell us a little bit more about the situation on the ground for women administering vaccines on the front line, and what kind of support would be most useful to them? Over to you, sir.
Thank you very much, Rustam, for your questions. Good morning, good afternoon, and I'd like to thank Ambassadors Lana, Alan, and Sofia for their introduction and for working together and inviting us and giving us this chance. In fact, answering your question, Rustam, the COVID-19 pandemic, we all know, brought us to the light, the importance and the essentiality of the essential role of community health workers in delivering health services, and the existing gaps at the same time in the availability preparedness, and protection, as you have all mentioned, of our healthcare workers in general, particularly female staff. But we all know that their fundamental work was well recognized before the COVID-19 pandemic. In polio, for example, especially in polio endemic and outbreak countries, community-based healthcare workers play critical roles in vaccination campaigns that starts from planning, identification of target group, community engagement, mobilization, and service delivery. Most community healthcare workers are members of the communities within which they work and are reflective of them as well. So that's why they gain their trust from that sort of concept. And therefore they are linked between, they work as a key link between their communities and the healthcare system and us as UN agencies. They are well positioned to help overcome access and equity barriers. They play an important role in vaccine promotion and acceptance as well, whether through community dialogue and engagement, through education, as has been shown in the video, trust building, breaking myths, on and offline social listening, or facilitating community entry. In polio endemic and outbreak countries, the majority of these healthcare workers are courageous women and are able to enter homes and vaccinate children, putting themselves sometimes into the risk. Putting themselves into sometimes hostile and dangerous environment. And it happened that some of them have been attacked, have been abused physically. The recent killing of 3 female polio vaccine providers in Afghanistan is a very tragic reminder of the numerous challenges, risks that those women are really facing every day to make sure that no child is really missed. Despite the wide recognition and the substantial evidence that their positive potential and important role in delivering essential services from polio to COVID-19 vaccines, I'm sorry to say that the support given to the healthcare workers and their integration into the system and communities are uneven across and within the countries. There is a need for sustained protection and investment in the workforce for systems resilience and preparedness. The specific needs of female healthcare workers and of those with greater vulnerability due to age, ethnicity, social determinants of health, or disability conditions should be addressed wherever we talk, wherever we discuss this issue, including in relation to safety issues, decent working conditions, and equal opportunities. Now, when it comes into women, as Her Excellency Ambassador Lana mentioned, women form approximately 70% of the health workers and are dramatically underrepresented when it comes into health leadership. They also undertake a substantial portion of unpaid and family care, including community healthcare workers who often are expected to volunteer or receive performance-based stipends. Female health and social workers therefore face double burden, if I may call it, of increased care responsibilities, both within and outside their homes. This perpetuates a cycle of under-evaluating, and evaluating of care of the women workforce. Now, when it comes into the Eastern Mediterranean region, it is not an exception, and it is really facing major healthcare workforce challenges with an overall shortage of qualified healthcare workers. The framework for action for health workforce development in the Eastern Mediterranean region 2017 to 2020 highlights the need for gender balance, cultural sensitivity, and innovation for strengthening the health workforce, including the promotion of female-friendly, family-friendly work environment, as you have mentioned, and conditions as well, such as adjustable working hours, favourable shifts, female amenities, childcare services as well. To address these challenges and report on the progress achieved, the 5-year action plan for health, employment, and inclusive economic growth will be presented to the World Health Assembly this year. The report presents a pathway for the continuation of its agenda and stresses the need to tackle gender workforce issues and women empowerment in particular, including through gender analysis to address inequities in the global workforce. The report notes that there is a mismatch between the urgency of the health workforce agenda for education, skills and jobs, and the political and financial support provided by the major G20 economies. The capital and recurrent costs of education and employment in the health sector receive a small share of official development assistance to health, and no major development agency has linked its education and gender policies or thematic funding to decent work and jobs for women in the health sector. My last remark, I must conclude by saying that health workers are not a cost. They are an investment with health, labor, equity, and economic dividends, either for the country itself, for their communities, or for the regions, or for the whole world. Community health workers' jobs can provide decent work, particularly for women and vulnerable populations, and we have seen it in many communities. To ensure quality, resources must be allocated to training, supervision, remuneration, supplies, and effective integration into health systems. And last but not least, the polio program has embraced this vision in a very wide manner, and in collaboration with sister agencies like UNICEF, CDC, other UN agencies, working on the ground, and in investing as well in the protection, training, empowerment of frontline workers, with special attention to female frontline workers and their needs. And here I must assure you that we are fully committed to make sure that healthcare community health workers are given their rights. They are well considered in all plans, in whatever discussions we make, and in particularly female healthcare workers. And as Her Excellency, the Ambassador Lena mentioned, they have to be included at the leadership level in order to make sure that we are really listening to them in the very right manner. And we are very much committed here in IMRO. Thank you very much, Rustom. Back to you.
Thank you, Dr. Ahmed, a passionate advocate for protection and support of frontline workers. And thank you for this great summary of what World Health Organization does in your region, ensuring support to female frontline workers. From here, I'd like to turn to UNICEF. I'd like to introduce Dr. Sagri Singh. Dr. Singh, UNICEF is one of the largest vaccine procurers and distributors in history. So what measures does UNICEF take to turn gender sensitization, as Ambassador Nustaiba said, standard operating procedures? What are some of the successes and failures you can share?
Thank you, Rustom, and good morning, good afternoon, everybody. I would really like to take this opportunity to thank Your Excellencies for hosting this dialogue and the opportunity to share UNICEF's efforts. As a global agency for child rights and equity, UNICEF is committed to gender equality and the empowerment of women and girls. And in our work with partners in over 100 countries, we do apply this principle when we engage with communities and distribute vaccines to ensure affordable access. Within this context, we know that gender-related barriers interact with other social, economic, and cultural factors and operate at multiple levels, from the individual and household to health systems. As all the speakers before me have alluded to this, we know that these are underpinned by gender power relations, leading to different opportunities, challenges, needs, and vulnerabilities, especially for women and girls, which affect both their access to and the provision of immunization. I won't delve into the details of what that looks like, but we know, for instance, mothers' lower status in the household and community impacts their inability to really act on their own and their child's behalf. And all have alluded to the healthcare workforce, that while they make up the bulk of the workforce, their voices and choices remain invisible in the health systems. In order to integrate gender equality considerations in immunization programs, I'd like to highlight 3 ways in which we are translating evidence into intentional action, because that's what we really want to see happen. 1, as part of a partnership with Gavi, WHO, UN University, UN Women, and multiple agencies, gender barriers and related solutions were analyzed from the existing literature and collated in a simple guide and checklist for managers and implementers for the equitable deployment of COVID-19 vaccinations. The checklist is aligned with COVID-19 national vaccine deployment plans and is being rolled out by agencies. Another is UNICEF's toolkit on human-centered design in immunization, which amplifies the voices of beneficiaries by working directly with them to define problems and co-develop solutions. This is a particularly effective way in making women and girls visible and their voices and the approach integrated in the solutions. And this approach UNICEF has integrated in our sub-national coverage and equity assessments. We know, for example, in Malawi, UNICEF conducted discussions with girls to build their understanding of HPV vaccinations, but also used this opportunity to co-create messages with them, to communicate about the vaccine to their peers and identify sources of information and the best ways to communicate with them. A third asset we are doing is developing an interactive online learning tool based on the evidence geared to managers and implementers that in simple terms identifies the gender barriers and solutions at every step of an immunization journey, from building knowledge and awareness at the community level to providing services and after-service care. The tool will be complemented by a compendium of promising and successful practical solutions. Where we have been successful as part of the global community is collating the evidence that is available, aligning our priorities and understanding what gender-related barriers are to immunization, and developing tools to integrate into immunization activities. But some challenges do remain, including changing the mindset to focus on gender barriers and uptake and access over differentials in coverage rates, limited understanding of the specific barriers and solutions to really the how, and embedding gender equality consideration within existing policies, protocols, and programs. And finally, as we look to solutions at the field level to improve vaccination outcomes for all, an integral area of focus is supporting female health workers. We already have heard a lot about it from our other speakers, but really gender pay gaps, gender-based occupational segregation, limited professional mobility, and the prevalence of sexual harassment in the workplace does negatively affect our female healthcare workers and their ability to deliver quality health services. And we have seen the stark reminder of what happened in Afghanistan with the 3 women polio vaccination health workers. So some solutions to overcome the challenges. Having more female supervisors and supportive supervision opportunities, as already been noted, is an effective strategy to keep female workers motivated and morale high. And this was noted in Pakistan, in Ethiopia, and South Africa, among other countries. Recruitment, selection, and remuneration policies, guidelines need to be monitored for health workers. We must apply a gender lens to mitigate any unintended consequences, such as the preferential selection of men for community health worker roles due to higher education levels. And finally, policies must also consider the multiple roles female frontline health workers play and support flexible schedules, childcare policies, and other considerations to retain female health workers. For example, in Mozambique, health worker training is located closer to women health workers live. UNICEF is conducting a gender analysis of policies and practice, particularly related to community health workforce in multiple countries in sub-Saharan Africa and South Asia, to better understand the gaps and entry points and to see where we might have the opportunity to work together to strengthen policies and investments to better support female frontline health workers. And finally, I'd just like to end with the words of Melissa Corkum, a polio outbreak response senior manager with UNICEF, who said, "Change won't happen if we don't change the way we think about involving women. We need to listen to their views and open the doors for more women to join." Thank you.
Thank you, Dr. For your summary of how UNICEF works in mainstreaming gender, and ensuring that voices of mothers and girls and females are brought into designing better vaccination programs. So from here, we'd like to move on to Jean Mundro, and I'd like to bring your views on the same question, given Gavi's enormous footprint in immunization. What is working? And what is not working? What does that mean for the next steps for reaching more children of the world with immunization? Over to you, Jean.
Thank you very much, Rustam, and thank you very much to the UAE for organizing this very important event. I think, as was said, there needs to be more discussions about this. There's a lot of misunderstanding when we use the term gender in immunization. So it's through forums like this that we can really promote learning and understanding. So Gavi, the Gavi approach is really based on identifying and reaching zero-dose children. And when we talk about zero-dose, those are children who have never been vaccinated. And the gender dimension is a key part of this new approach of Gavi. We have a new policy that was identified and developed last year. There needs to be more discussions about this. There's a lot of misunderstanding when we use the term. Sorry, are you able to hear me? So it's through forums like this that we can really promote learning and understanding.
Yes, go ahead, Jean.
Rustam, I think there's a bit of an echo, but okay. So our new policy talks about having a gender responsive or a gender transformative to immunization programming. So to do this, we need to understand the dimensions, the barriers that are faced by our healthcare workers in providing quality services, as well as the dimensions that inhibit parents, caregivers, and taking their children for vaccination, and also the restrictions faced by adolescents, particularly in accessing HPV vaccines. Some of the challenges, many of the challenges have already been said by my colleagues, but I'd just like to go back to that misunderstanding of what is meant by gender and immunization. And certainly in discussions with colleagues, there's a belief that we're just talking about parity in terms of who is being vaccinated. And there's a belief that if there's equal vaccination of both boys and girls, then there are no gender issues. So I'd like to underscore that that's not what we're talking about when we say gender and immunization. We're really looking at the norms and traditions that can support or restrict a caregiver in taking their children for vaccination or a healthcare provider in providing quality health services. So the solutions that Gavi is working on is primarily based on the idea that we are an alliance of health partners, and it's by having this collective approach that we're making a difference. So I talked about the gender policy that Gavi has developed. Our other partners are developing similar policies with very much the same approach. And I think this is an important aspect of it. We're very intentional when we talk about gender, meaning that right from when we support countries in the design of their immunization program, they need to do a gender analysis to identify where the barriers are, why there are barriers, and to work with communities using approaches like human-centered design to identify approaches that will fit the community, but also that are addressing the barriers that are identified. A key new approach that we're taking is to ensure that women's voices are included in the design stage of any immunization program. And as colleagues have said, there has been limited involvement of women to date in the design of immunization programs. Yes, they're the ones delivering, but in the design, monitoring and evaluation, their voice has been limited. So that's a key aspect of what we're doing. And that analysis helps us understand who's receiving the vaccinations, who's dropping out of vaccination programs, which is particularly important right now with the COVID situation, and most importantly, why there's this dropout. So I'd like to just share with you, Rustam, a little bit more about some of the solutions that look very promising. In India, there is a program called Safal Sharat, which means successful beginning. And it's using three approaches that we feel will have large dividends. The first is that it engages men. The second is that they use couple counseling. And the third is that it integrates immunization services into other services that family members need. So engaging men, I know we've talked a lot about putting women at the fore, but we also know that women as a caregiver are already overburdened with their work, with the homework, with their different roles. So engaging men in immunization services is a way to lessen that burden, but also a way to address some of the decision-making inequities that can be found within families. We also see an example of engaging men in the program in Togo called Papa Champions. And there we see that men are engaged as a caregiver, so to promote them in taking their children for vaccinations, but they're also used as community change agents for promoting improved immunization awareness within the communities. So those are two examples of transformative interventions. When we talk about transformative, we're changing the gender dynamics to have greater equity. There's also an example of a gender responsive program. Responsive means we understand the gender norm and we identify an intervention that takes it into consideration, but doesn't necessarily change it. So the example there is in Senegal, where it was realized that women were not able to bring their children for vaccinations because of the time when the clinic was being run. So they changed the time, so this now allowed more women to enter. So again, that's a responsive approach, but not a transformative approach. So with that, I'd like to leave it there, and I look forward to our further discussion. Thank you.
June, thank you very much. We're really, really interesting examples of how we can engage men in gender mainstreaming and the role of fathers and males in really ensuring that we reach and improve vaccination services for children all over the world. So from here, I'd like to move on to and introduce Dr. Bastian Taylor. So Dr. Taylor, to close out the panel, I'd be grateful if you could illuminate to us some of the lessons that you have learned from your very much hands-on work in Afghanistan and maybe other countries. How can women in household and community be supported in improving vaccination outcomes for their children? And on the other side of the equation that Dr. Ahmed raised, what are the most effective kinds of support, do you think, for female immunization services in that equation? Please, over to you, Dr. Taylor.
Thanks very much, Rustam, and thanks, Excellencies, for this opportunity to speak to this forum. I'm going to focus on mass immunization programs like polio, which rely on an outreach interaction between programs and communities. I think it's fairly clear, as has been said today, that the polio program has advanced in very impressive ways in its engagement with gender. But I think it's true to say there is a long way to go yet. Just to give you an example, which kind of implicates myself, I sit on the technical advisory group for Pakistan and Afghanistan, which has not had female representation for some time. Now, that is in the process of being rectified, and that's great. But the fact is, it has taken some time to get there. I want to start with a general observation. There is, when you look at the literature, an enormous amount of emphasis and production around gender analysis, but there is much less evidence of the successful translation of that into implementation, which narrows the gaps of gender power that we see all around us programmatically. And I believe what we need is a more intelligent, a more grounded approach to what we mean by gender. Too often, gender is interpreted as meaning women. And too often, we talk about women as if they were a single homogeneous group rather than real people with diverse identities, preferences, motivations, challenges. And certainly when we talk about women's instincts, often it is men talking about them rather than women, which gives us a very skewed view of the world, in particular their preference for payment. Too often, women are viewed, particularly in immunization, as a kind of magic bullet. Mothers are assumed somehow to be naturally inclined to accept vaccination, and female vaccinators are assumed to be the ones who will reliably gain access to households and the trust of those inside those households. Now, often that is true, and we see that in the programs day to day. But I think we don't do ourselves any favors when we overgeneralize or oversimplify the realities of women in households and in program work. I think we need a broader approach to gender. And what I mean by that is to develop operational research, which helps us to understand the social ecology of the interaction between men and women. This is not just about women. It is about understanding power dynamics within households, power dynamics within programs, and how those change over time. And certainly how, where we see an equalization of those power dynamics, we see much, much better outcomes in terms of program performance and in terms of household access. So then, turning to the questions, Rustam, that you asked me, on the one hand, how might a more properly gendered approach support households in improving immunization outcomes? I think the first thing to observe there is that actually the rates of immunization between boys and girls, looking at countries around the world, are comparatively equitable. I'm not entirely sure that the problem is the outcome. I think the problem in gender terms is the process within those households. Much immunization, communication, and engagement work focuses on individual knowledge and behavior change, often focusing on that knowledge and behavior relating to women rather than relating to gender within the household. That doesn't help us to understand what is going on in decision-making terms in complex households embedded in complex communities. I think we need to focus on understanding those gender dynamics within households and within communities. And in particular, I think there is an opportunity to focus more on what happens at community level, because what we see is that vaccine behavior tends to cluster amongst households, not just be randomly distributed within them. And there is clearly a gender function going on there. We also need to recognize that gender is not a fixed quantity. We know that the influence of gender changes substantially when you move from rural communities through peri-urban communities to urban communities. And we need to develop our ability to understand what that means in terms of our engagement with those communities and households. Just as an example, we've seen in Afghanistan recently some very promising developments, I believe, on the one hand, looking at the potential influences of the extended family, including grandmothers, for example, in the decision-making process. And on the other side, looking at a more active engagement with community-based organizations representing women's issues and women's rights. Now, again, I would say this has been some time in coming, but it's very promising to see it happening now. Turning to the other side, Rostam, as you say, of the equation, what might we do from a gender perspective to support immunization workers to do their job? Clearly, the polio program has done a lot recently to extend its ability to recruit female frontline workers. But again, female frontline workers are not simply a tool that the program uses. They are people with identities and skill sets. And unless we treat them that way, unless the program engages with them in that way, it will not get the benefits that we are talking about today. As an example, I was talking to a female frontline worker in Kandahar recently who said to me perfectly straightforwardly, look, you can't just say that we female vaccinators are the answer all the time. Sometimes we are, and sometimes we need male counterparts in combination. I think we need that nuance in the way in which we understand what female frontline workers are able to do. We should not treat female frontline workers as a program commodity, recruited, as it were, under duress from communities which don't accept this practice, because what we end up with then is having to circumnavigate those female frontline workers with security forces, or with practices like Muharram in Afghanistan, a kind of chaperone system, which, whilst it may facilitate the process, actually reproduces the gender problems that we saw in the past. We need, I think, in this respect, human-centered design focused on recruitment, where we engage with communities, men and women, so that we can get their support for the idea of recruiting women. Because it's that support that will provide ultimately the protection for those women who very bravely take on this kind of role. I'm going to finish in just a moment. I think there are a couple of other things for frontline workers, for female frontline workers. The first is that we need to think much more closely about their profile and their training needs in particular. I think often they go through a relatively two-dimensional process and are then deployed. And on the other side of that, I think we need to have program facilities in place to listen to their experience, because they know what is happening at the doorstep, but I don't think it's being fed reliably back into the system. What that means is that we need not just frontline workers who are women, we need their supervisors to be women. But that's not all. We need women and men in a much better balance all the way up the system. And now this has been referred to by the other speakers, and I'm not going to go over it again, but the fact is many programs in health, many programs in immunization are a flat pyramid in which you have lots of representation of women at the base, and they just disappear as you go up towards the operational and strategic levels. It's not the way it should work. We need women and men in parity all the way up the system. And until we get that, we're not going to get the benefit of the gendered approach that we are talking about today. Finally, therefore, what couple of things might this group consider? On the one hand, I think investment in an ecological approach to understanding gender in households, in communities, within programs themselves. Operational research, which can quickly be translated back into operational strategy. That's key, I think, to really making gender an operable proposition. And secondly, I think we need active support right now to restructure the gender balance in those programs. This is not something that can wait till later on. I think there is an opportunity right now to go back and have a look at this in detail from the front line all the way through the districts and provinces back to capitals. I'll leave it there. Thanks very much.
Thank you, Sebastian, for very much contextualized sort of examples of complex sort of dynamics between men and women, and how these can be sort of utilized in the vaccination programs. And thank you all panelists for compelling perspectives and recommendations, very practical. So as our last set of voices in the panel, we'll play a short video from Nigeria, which, as you may know, have eradicated polio. Congratulations to Nigeria. And in part, there was a major role of female frontline workers who made it possible. I'd like our Ask IT team to show us this short clip.
We're in Borno State, where we had the last case of wild polio virus. The insurgency in Borno has made it impossible for communities to access basic services for over 11 years. In order to reach every last child, we have trained and deployed over 20,000 volunteer community mobilizers. These brave volunteers, mostly women, are the backbone of the polio eradication program. They walk house to house daily, even in areas that threaten their own safety, to convince women and families to vaccinate their children.
Lafiyar al'umma haƙƙin kowa da kowa ne. This means that the health of the people is related to everybody. Everybody has to come and put hands together so that we should improve our health.
Wato chabrola den kringtu diwilan zora kringe raki wangana taida. Amma da yanzu isa asun yawo da zabura kijin zufanya ardinge. Changawo da manga makol nge kono so maraga kana.
That is where the partnership of local influencers like traditional leaders, religious leaders, polio survivors have been critical in keeping polio out of Nigeria for the past 3 years. The vast community network has helped us open windows into the most vulnerable communities. Not only strive to ending all forms of polio, but also provide other critical services for the well-being of all children in Nigeria.
Excellencies, colleagues, I've now opened the floor for your reactions, questions, and recommendations. gender sensitization into immunization. And I already have a number of requests on the floor that I'd like that I'm prioritizing at the moment, but please feel free to raise your hand or maybe add your questions to the comment box in case we are not able to get to you, given that we have just really 5 minutes left of this session, and we'll try to get back to you with the responses. So for our first speaker, it is my pleasure to call on Munir Akram, the permanent representative. Ambassador, please, the floor is yours.
Thank you very much, Mr. Moderator. And I'd like to thank Ambassador Lana Nusebi for organizing this very timely discussion on gender and immunization. As you all may be aware, Pakistan has had a specific and monumental challenge in the campaign for vaccination against polio. And obviously the causes of these have been diverse. The existence of a large refugee population from Afghanistan, the problem of terrorism, as well as the disinformation campaigns which have propagated against vaccination in a society which is very conservative. We have 177,000 health workers. Out of these, 100,000 are female. So about 60% of our health workers are female. And obviously they have borne the brunt of the backlash from the disinformation campaign that was propagated against vaccination on polio. We have gone forward. We have developed a huge amount of data from the efforts. Terrorism has been rolled back, and therefore we have been able to access everybody. And the polio campaign is proceeding. We are very close to eliminating polio as a result of this campaign, and we are very hopeful of achieving this. Security teams, unfortunately, have had to be deployed with the female workers, and female workers have had to be used because of the conservative nature of the society, to be able to get to the women and get into households and to vaccinate girls and women. The brunt of the effort has fallen on the female health workers, and we have tried to provide security. Number of incidents is now minimal. Most of it is usually in the form of street crime, rather than the more organized kind of disinformation that we faced in the earlier parts of this campaign. I think it's important to see that our campaign is, of course, led nominally by a person, but it is overseen at the federal government level by Dr. Sania Nishtar, who's the head of our EHSAS or Compassion Program, by our Minister for Human Rights, Shireen Mazari, and they have close oversight on what takes place with regard to this campaign. I just thought it would be useful to indicate that the data which was collected for the polio campaign is become absolutely vital in the campaign that we now will have to vaccinate against COVID-19. And we will use the same SOPs, the same data, and that data has enabled us to provide a cash support program to about 15 million people, and a large majority of these people have been women-led households, so that the cash program has empowered women, and they are now able to be in a position to decide with regard to decisions regarding their family. So it will be vital for us in the vaccination program that is underway for COVID-19. I cannot end but say that at this time, we need to mobilize to get equitable access to the COVID-19 vaccine. The production of the vaccine, waiver from the intellectual property, the TRIPS restrictions, distribution equitably in developing countries. This is vital, I think a vital challenge that we all face. And of course, the brunt and the leadership will have to be taken by the women health workers who are prominent in so many developing countries, including my own. So thank you for this opportunity. I thought it was important that I intervene and inform you about the status in Pakistan.
Thank you, Akram. This was a great intervention and certainly highlighting a major Pakistan program is making in protecting frontline workers. You mentioned something very interesting about misinformation-based fake news, which is certainly a major issue in the current context, vaccination context globally, and that is a very interesting dimension. I think that we have brought into this conversation. So, thank you very much. From here on, I'd like to give the floor to Ambassador Fiona Webster, Deputy Permanent Representative of Australia. Please, Ambassador, the floor is yours.
Thank you so much, Rustam, and thanks to the UAE and the UN Foundation and GPEI for hosting this session. It's extremely timely. Something that I like to say when confronting a complex problem without underestimating its complexity is it's not rocket science. And in listening to all of you today, I say at a very high level, it's not rocket science. Women must be included in our efforts to reach the hardest to reach, to immunise the hardest to reach populations. They are, as we know, uniquely placed and uniquely trusted to access and deliver vaccines. But we do need to understand how to do that more effectively. And I echo Dr. Taylor's insistence that we need to understand better the processes through which we engage women in households and communities and men with complex power dynamics at play. So I support that need that Dr. Taylor has mentioned for further research, which can link effectively into our strategies around engaging women. So we've heard a lot today about the essential role that women play in supporting vaccine coverage as vaccinators, vaccine recipients and caregivers, running health programs, building trust and addressing vaccine hesitancy. I share the concerns of those who've spoken before me about the barriers women face in supporting immunisation. No one should have to worry about being harassed or stigmatised or face violence when trying to look after the health of themselves, of their families and their community. To that end, I'd really like to extend Australia's appreciation for the tireless efforts of Gavi, the Global Polio Eradication Initiative, and partners including UNICEF and the World Health Organization. It's absolutely critical that the global responses to the health crises we've talked about today, from the COVID-19 response to the administration of polio vaccines, are gender responsive and improve accessibility for our most vulnerable populations. GPEI's 2019 gender strategy is a key piece of work in this space. We sincerely hope that the vision that's articulated in that strategy is embedded in the updated GPEI eradication strategy, so that the voice of women is heard at every level of the organisation, as Dr. Taylor mentioned, and that they're fully supported as they drive progress in polio eradication. As Churchill once said, we should never let a good crisis go to waste. And as we've responded to various health crises, we've learnt different lessons about what has and what hasn't worked in relation to tackling gender barriers to immunisations. It's important that we share, as we're doing here, that information and that we cross-pollinate our responses so we can address this issue across the board. Now is the time for even more coordinated international actions to build stronger systems for routine immunisation and primary health care. And Australia looks forward to working with all of you to achieve this. Thanks very much.
Thank you, Ambassador, for highlighting particularly the need for better understanding of corporate dynamics, the need for gender desegregated data, more research and social research, vaccination progress incorporating the gender. So from here, I'd like, we have, I think, time for one more and probably last. I'd like to invite and call upon the permanent representative of Nigeria, Ambassador Chijani Muhammad Bande, who is represented by Minister Namdi Nze. Minister, the floor is yours.
Good morning. Thank you, everybody. Your Excellencies, ladies, distinguished ladies and gentlemen, let me apologize on behalf of Ambassador Tijani Bande, who is unavoidably absent, and they have asked me to read a short statement which he had prepared. Your Excellencies, at the outset, I would like to thank the organizers of this event for inviting me to add my voice to the global efforts to carry out immunization in a sustainable manner. The topic, gender and immunization, polio to COVID-19, is not only dear to my heart, but also relates to the experience in my country, Nigeria. Allow me to extend my heartfelt condolences to all those who have lost dear ones from the pandemic, and to also extend my best wishes for the recovery of those who are ill. In August 2020, when the COVID-19 pandemic raged, Nigeria was declared polio-free. The path to this declaration would not have been possible without the robust involvement of all stakeholders, given that Nigeria accounted for more than half of all global cases less than a decade ago, according to World Health Organization sources. I would like to highlight that the vaccination campaign in Nigeria involved a huge effort to reach remote and dangerous places under threats from militant violence, and some health workers were even killed in the process. The achievement would certainly have been possible without the novel strategies adopted in the consistent fight against polio and other vaccine-preventable diseases. Your Excellencies, the successful eradication of polio was possible because of the power of partnership and the power of solidarity. The Global Polio Eradication Initiative, GPEI, played a significant role in Nigeria's long journey in becoming polio-free. Our partners in this journey were the Global Alliance for Vaccine and Immunization, Gavi, Bill and Melinda Gates Foundation, Rotary International, CDC, UNICEF, the Dangote Foundation. Equally important in achieving this milestone was the strong domestic and global financing and commitment of government at all levels. From our experience, it was evident that innovation, partnership, and resolve have all underpinned advancements made in Nigeria, together with the commitments of tens of thousands of health workers. The GPEI partners can attest to the vital role of women in ensuring the success of the immunization program in Nigeria. These women, mostly from rural communities, played significant roles in the engagement strategy that changed the narrative in favor of immunization. It will not be out of place to claim that the marginalization of most of these critical stakeholders, especially women, was instrumental to the failure of previous polio immunization endeavors. On this note, I salute GPEI and other partners for their gender-responsive organizational culture. Excellencies, Nigeria's unique experience in eradicating polio attests to the heightened utilities of vaccines to protect mankind from pandemics. Experience has shown that low and middle income earners represent the demography that is most hit by any crisis. Coincidentally, women make up the highest population in this group. In the last 1 year of the pandemic, women and girls were worst affected via livelihood and job losses, unavoidably providing care, exposure to health hazards, and several setbacks based on their peculiar situations. As natural caregivers, these women have been at the receiving end of tending to the sick and so have experienced more deaths and trauma during the pandemic. In many instances, they have less access to vaccines while they care for the sick. They are also underrepresented among vaccine workers. Sadly, this scenario repeats itself during every health care. We should therefore seize the momentum of the COVID-19 vaccine programs to improve on the mistakes of polio immunization. It is high time we acknowledged that by limiting women's access to vaccines, we also reinforce their victimhood. My delegation believes that women's critical role in the productivity of families and societies is indicative of what to expect if they are empowered in all aspects of human endeavors. We must therefore see gender as a matter of social justice enshrined in the Universal Declaration of Human Rights. By recognizing gender, inadvertently, we strengthen immunization outcomes. In conclusion, it is only with such mindset that we can overcome the stereotypes that hinder women from being fully represented in the value chain of immunization. I thank you.
Thank you, Minister, for your context of Nigeria and sharing your experiences. This is really great, really moving forward with with the immunization program globally, keeping the momentum. So I think that's that brings us almost to the closure of our event. Now, as our final intervention, I'd like now to cross and beam in Wendy Morton across the Atlantic, UK Minister for European Neighbourhood, and is also a passionate polio gender champion and has been working to take the gender lessons from polio to immunization and other efforts in COVID-19. So over to you.
The COVID pandemic has pushed vaccines and vaccination programs to the top of the political and health agenda right around the world. In the rush to get needles in arms, it's so important that we do not overlook the lessons we have learned from past vaccination programs. So thank you to Ambassador Nazibe and our Emirati friends, to Ambassador Borges and all her colleagues at the United Nations Foundation, and to everyone at the Global Polio Eradication Initiative for concentrating our minds today on the absolute necessity to weave a gender perspective throughout the entire fabric of any successful vaccination programme. As a global polio gender champion, I appreciate this opportunity to add my voice to the cause. Despite countless inspirational examples of women on the vaccination front line, providing the backbone to many eradication programmes. Despite the success of the tireless Heather Mona from the WHO's Polio Eradication Programme in getting polio eradicators around the world to put on their gender glasses, there are still some who pay lip service to gender, who see it as an add-on or a nice to have. Events like this are essential if we are to win over those remaining sceptics. So let's go from here and tell them about the transformational impact that women had on the polio eradication programme. How local women reached into their communities and educated people, built trust and administered vaccines, and gained access in a way that outsiders could not. Let us remind them that no programme succeeds if it neglects the lived realities of half its target community. The sad reality of the COVID pandemic is that it has often hit women's livelihoods and opportunities the hardest, and it has further prized open the gender gap. It is essential that we challenge this at every opportunity and ensure women are listened to, helped and protected, and that they receive equitable access to COVID-19 vaccines. The UK government has committed over £500 million to the COVAX initiative, and we're using our G7 presidency to champion equitable access. This must include equitable access for women, including those who are hard to reach. As we all know, none of us are safe from infectious disease until all of us are safe. So incorporating a gender perspective into immunisation programmes is something that will make us all safer. So let us send a collective call to action from this meeting to all governments and healthcare agencies. If you want to protect your entire population, include women at every stage of your immunisation programme. If you want to get on the fast track to making gender equality in immunisation a reality and everyone safer, support female leaders, female policymakers, female health workers and female vaccinators. It is that simple. Thank you.
Thank you, Mr. For your closing remark, and certainly we should be more serious about it and not doing a lip service, as you put it, and not a nice to have. Gender is not a nice to have element of the program, but really essential. So, Excellencies, colleagues, that brings us to the end of our agenda. Very interesting hour. Thank you for your participation and perspectives. That was amazing, and certainly with all the enthusiasm that this group demonstrated, I'm very certain partners will move forward, operationalizing and acting upon this very specific recommendation. So the co-host of this event will be holding up with a short summary of these ideas, and these conversations will continue further. The recording of this event will be available at the United Arab Emirates United Nations website, which is uaeun.org/UNSC, and that website, I'm sure you will be sharing with you the recordings of that. Also, thank the IT team and colleagues that work on the background of all that. It took a lot of effort, and I apologize for any hiccups that we've had with the technology. That's about it. Thank you again. Eid Mubarak to those celebrating, and wishing you a very good weekend. Thank you.